Hello, can I request everybody to please settle down and take your seats? Thank you. Yeah, can we settle down a little faster? Good morning, everyone.
Good morning. Good morning.
So I welcome you all to the brightest Sunday morning that you all have ever woken up to. I would like to let us all rise up for the prayer song, please. I would like to invite Sangeeta also to please join me.
Good morning, all of you.
Guru Brahma Guru Vishnu Guru Deva Maheshwara Guru Sakshat Parabrahma Tasmai Shri Guru Deva Namah Tasmai Shri Guru Deva Namah Vakratunda Mahakaya Surya Koti Samaprabha Nirvighnam Kuru Me Devo Sarvakaryeshu Sarvada Sarvakaryeshu Sarvada. I would like Sangeeta to join now for the Humko Man Ki Shakti Dena song. Please.
All of you
Can we
sit
all
down.
sing together?
हमको मन की शक्ति देना मन विजय करे दूसरों की जय से पहले खुद की जय करे हमको मन की शक्ति देना मुश्किलें पड़े जो हम पे इतना कर्म कर साथ दे तो धर्म का चले तो धर्म पर खुद पे हौसला रहे बदी से ना डरे दूसरों की जय से पहले खुद की जय करे हमको मन की शक्ति देना हमको मन की शक्ति देना हमको मन की शक्ति देना.
Thank you so much, Sangeeta.
Thank you, Tejal. Thank you.
I would now like to invite our first keynote speaker. He's Dr. George Capone. I would like to give a brief introduction about him. He's a research scientist and a director of the Down Syndrome Clinic and Research Center. He has been in this since last 30 years at the Kennedy Krieger Institute and is also an associate professor of pediatric at the Johns Hopkins University School of Medicine. I would like to give him a warm welcome. Please, sir. Please come.
Okay, thank you.
I would also welcome Dr. Sujata Jagdish, the chairperson today. Yeah, she's been working with Dr. S. Suresh at Mediscan for nearly 20 years. She is an authority in her field and has a lot of publications to her credit. She has presented at many international and national forums. I welcome her.
Well, thank you. Good morning, everyone. Congratulations on the first International Congress here in New Delhi. It's really remarkable. This is my second time to India. I was fortunate enough to be in Chennai 2 years ago for the World Congress, and Dr. Rika invited me there and fortunately felt like she could invite me back. So I want to thank her, Brenda, and the entire committee for putting this together. For someone who comes from far away, I really feel blessed to be here, and I think you make me feel very welcome, so thank you. Okay, so there's the slide. So my topic this morning is going to be to talk about adult health and mental health concerns. I've been with the Down Syndrome Clinic in Baltimore for about 30 years, and you know, in the early days we started off seeing mostly the young children, and we're doing sort of traditional developmental assessments. And then over the ensuing years, it became necessary and desirable to see the older individuals who are well beyond the pediatric age group. So that's been an amazing journey and a very interesting one from my perspective. And even though I'm only trained in pediatrics, I think it was one of the better choices that I made because it's added so much to my understanding. So people with Down syndrome, as we know, are seen in every part of the globe. And we estimate that there's maybe 6 to 7 million people on the planet with Down syndrome. And with the population ever increasing, we expect that there will be more people than ever with Down syndrome. In many parts of the world, longevity is increasing, and we are faced with new challenges in terms of understanding their mental and physical health needs. So we do recognize that there are specific health conditions that are associated with Down syndrome. And you know, in many parts of the world, there's been increase in availability and access to services and improved opportunities for people to participate in health-related research. And we want to be able to bring that to more parts of the world and to people all over to benefit from our understanding and development. Because a lot of these healthcare advances haven't been evenly distributed, as you might expect. In some cases, it's limited by access to knowledge or resources. In other cases, it has to do with how to approach individuals who are unfamiliar to many physicians or seen as, you know, very complex. So we want to help to demystify that for the rest of the medical world, if you will. Now, Dr. Puschel was a world authority on Down syndrome for much of his life, and he understood that there were different types of medical concerns. So starting with the neonatal or the birth anomalies and conditions that were present in the newborn period. There's also then acquired medical illnesses that come up during childhood or early adulthood, and then there's aging-related medical conditions that we see in our older adults. And some of the barriers specific to caring for adults, again, includes the unfamiliarity of many physicians with people with Down syndrome, because adult medicine doesn't have a great amount of exposure to children with genetic or neurodevelopmental disorders. So whereas in pediatrics, it's very comfortable for many pediatricians, but for adult trained physicians, it's not so easily understood. The presentation of some conditions can be different in people with Down syndrome, and it can be clouded by the fact that there's intellectual disability present. There's often problems with verbal communication, and so we're very dependent on caretakers and our knowledge of the situation prior to the onset of whatever concern it is you're being asked to evaluate. And then in some countries and in some parts of the world, it's really a matter of access. And access may be actually denied or prohibited to people with Down syndrome for various reasons. So that may exist at the policy level. So these are other barriers that we are working against. Now, some of the common health care issues that we see in adults are somewhat similar to what are seen in the children. So vision and hearing concerns continue to be present. We need to follow the individuals who had heart disease as children and underwent surgical repair, because sometimes the surgical repair, for lack of a better word, doesn't last as long as we thought. We also have valves that start to leak, and we may have a condition called pulmonary hypertension or high blood pressure in the lung circuit, which can result in increased morbidity. There's problems with GI tract, not just constipation and slow gut motility, but even reflux and esophagitis, which can cause pain and interfere with swallowing and eating. Problems with thyroid continue in adulthood. We even see many individuals with inadequate vitamin D, and there may be consequences for bone health. We frequently see low bone density in both men and women with Down syndrome. By around the age 40, you may see that. So these are some of the things that are a little different from what we see in children. But the ones that I was most concerned about as really high impact health issues, in part because they're difficult to treat, and in part because they're very chronic and long lasting. And I think that there's an interaction among these things that make the situation perhaps a little more complex to both understand and treat in people with Down syndrome. So I'm talking about the propensity to gain weight over time. Even despite good physical activity and a healthy diet, we do see some individuals who are still prone to gaining weight. Sleep problems are very common, both sleep apnea, where you have obstructed upper airway, as well as disturbed sleep for other reasons, which may not be apnea. And then finally, we have a predisposition for mental health problems, particularly things like depression, anxiety, and compulsive disorders, and behavior issues that may be resulting from some of these underlying psychiatric symptoms or features. So the prevalence of obesity, which is defined as a body mass index over 30, is at least 40%, and if you include overweight and obesity, it may be closer to 65 or 70%. Now, admittedly, these are older studies, mostly from Europe and the US, and my sense is that things may be better in India. But in any event, it is a predisposition that we see, and it seems to be higher than individuals with other forms of intellectual disability. Although we are beginning to understand some of the biological reasons for the predisposition, I wouldn't say we understand it very well, or at least not well enough to bring in specific kinds of prevention strategies and treatments. So we're relying on the old standbys of a good amount of physical activity and a healthy diet. So some of the problems that may be related to chronic overweight or obesity include emotional issues, mood disorders, problems with self-esteem, fatigue, maybe low alertness, a predisposition towards high triglycerides and high blood sugar. You can have an effect on estrogen production and on the hormones that are involved in appetite regulation. Obesity can make sleep worse. It can make physical activity more difficult, and it can result in, aches and pains upon walking or upon exertion. So that hip pain, back pain, ankle pain, and then that may predispose to further levels of weight gain. So it can become a vicious cycle. And if you have this in the setting of sleep problems and in the setting of mental health concerns, it can really be a rather sticky wicket, which is difficult to get out of. So we like to think that prevention is the key and early treatment is the key. The emphasis, of course, is on healthy diet, meal planning. In some families where kids have free access to food whenever they want and whatever they want, we really have to be more careful about that. Whose phone is that?
Yeah, sorry.
Okay, thank you. Yeah, in the U.S. we have work centers and day centers for many of our adults, or they're out in the community doing a great deal of community-based activity. But in the push for independence, if they have money in their pocket and there's vending machines or there's vendors on the street, you need to just be aware that some people may choose to just buy food whenever and wherever they want. So independence is wonderful, but there also needs to be a way for people to understand that they need to control urges and appetites. And then most of the activity that seems to be the best in terms of successfully helping to manage weight is structured activity, where you're part of a group that's dancing, swimming, doing other kinds of physical activity. Being in the water is a very good form of exercise because it gives support to the joints and the muscles, kind of an anti-gravity effect. So you can do more, and you get a lot of resistance, so you get a pretty good workout. So hopefully that kind of thing is fun. In the States, we have a lot of people who have pets, and they go out and walk their dogs, or some people even have a trainer. They may have a one-on-one trainer who goes to the local gym with them and teaches them how to work on the exercise machines. So whatever it takes to engage the person to keep them physically active, whatever is successful for you, that's what's important. Some of the risk factors for obesity that we know of include estrogens in the case of females, the fact that people with Down syndrome may have a lower resting metabolic rate, may not burn calories as quickly. Insulin resistance is something that develops in the setting of obesity and can be a predisposing factor for the development of type 2 diabetes. So while we do see this in people with Down syndrome, I'm actually surprised we don't see more of it. So I don't know what the role is of insulin resistance in people with Down syndrome in a general sense. Hypothyroidism, if thyroid is low and free T4 is low, you can get a tendency for weight gain and slowing and mood changes. In the States, we're always checking thyroid, always. And so very few cases of obesity or even mood disturbance can be explained by frank hypothyroidism. But it's on the list, clearly. Eating disorders can result from obesity as well as cause obesity. The appetite regulating hormones may be disturbed, and you can develop something called leptin resistance, which is the signal for the brain to stop eating. And people often have very high levels of leptin that they don't respond to. So frequently we hear from parents, well, he or she doesn't know when he's full or doesn't know when he's had enough. That's a common report. Oral birth control pills that contain estrogen can also contribute to weight gain. And some of the medicines we use to help people, some of the psychiatric medicines, some of the newer antidepressants and the newer antipsychotic medicines can contribute to weight gain. So it's always important when you see people in follow-up, not just to look at weight, but to really reanalyze the risk versus benefit ratio. Is this person on this medicine for the reasons we think they should be? What are the risks of lowering it or taking it away or switching to something that may not cause as much weight gain? These are all things that we should reconsider at each visit. Okay, on to sleep apnea. So the risk for sleep apnea in people with Down syndrome, it's not just related to children with large tonsils, but in adults, there's other risk factors, other upper airway factors that have to do with the anatomy and the crowding of the airway and even the muscle tone of the airway itself. Obesity plays a contributing role. However, I should say that I do see many adults with Down syndrome and sleep apnea who are not obese. So you don't want that to be your only consideration when thinking about a sleep disorder. And we think that as many as 50 or 60% of people who have sleep apnea have a moderate or severe form of sleep apnea. So my concern is that when it's present, it's more significant than, say, people in the general population. The common symptoms include nighttime symptoms of snoring, respiratory pauses for greater than 5 or 10 seconds, gasping, sitting up in your sleep, jerking movements, frequent repositioning. But these things are not always obvious, in part because the parents are also asleep. And sometimes the most significant symptoms occur between 2 and 5 or 2 and 6 a.m. during the second half of the night. Some of the daytime symptoms that we may see include napping, loss of initiative or loss of energy, slowing, poor attention, mood changes, and some tendency for social withdrawal. And it can be difficult to try and tease out, what's related to sleep apnea, what's related to a mental health condition. And in many situations, you have both present at the same time, which makes the situation rather challenging. So I am going to talk a little bit about that. In the most significant cases, we see people who present with a lot of symptoms of a major depression, where they'll have loss of interest in activities. They'll have sleep problems. They may have weight gain. There may be sadness. But interestingly, in people with sleep apnea, we don't often see a lot of crying or a lot of irritability, whereas in a true depression, we more often see crying and irritability. And in people with sleep apnea, it's more of an apathy and a withdrawal and a slowing, but it can look very much the same. In any event, people in that situation are prone to losing the skills that they had worked so hard to achieve as children and young adults. So that's always a huge red flag when a 22-year-old loses their interest and their ability to get up and out of bed or get dressed in the morning or goes in the bathroom and stands in front of the mirror and stares at the mirror for 15 minutes without washing up or brushing their teeth, and they need constant reminding and prompting. So that, of course, is a big red flag, and I can tell you right now it's not Alzheimer's dementia. Not in a 22-year-old, probably not in a 32-year-old. Okay, that comes later. So you don't want to go with someone who just says this is early Alzheimer's dementia at age 22. I mean, I really think we need to be looking for other factors that are treatable, and this is what I'm telling you about now. The other thing we see in the setting of sleep problems or sleep apnea is more of an intensification in people who had anxiety or compulsive features. So they may exist at a level that's somewhat tolerable, somewhat manageable, and doesn't really impair their day-to-day function, although it may be something of a nuisance for the people around them. And sometimes we see these things intensify in the setting of poor sleep. Prevention for sleep apnea includes, if you look at the bottom, the airway treatment, which includes a CPAP, continuous positive airway pressure, or bi-level airway pressure. Some people who can't tolerate that might try to use an oral or dental appliance to pull the jaw forward and kind of reposition the tongue in a more forward position. In extreme cases where neither of these work, people have resorted to airway surgery. But this can be quite involved and painful, and it needs to be done at a center who really understands what needs to be done and how it needs to be done. So you don't do this too casually. If all else fails, or if you're just not willing to take on the battle, so to speak, of positive airway pressure, then positioning therapy becomes the standard. If you can get someone to sleep semi-reclined or either in a reclining chair, or if you have a wedge to prop up the head of the bed so they're at about 30 degrees, you can actually minimize some of the airway symptoms in that way. So sleep is very important in humans. We spend 30% of our lifetime asleep. Some people more, some people less. The first half of sleep is dominated by slow wave sleep and non-REM sleep. And the second half of the night, REM sleep is much more common. And that's when you have a lot of dreams and you have a lot of... the body is essentially... paralyzed. The tone is minimized so that when you're dreaming vivid dreams and you're running away from some demon, you're not actually literally running out of bed. The body is paralyzed. So in that stage, muscle tone is reduced, and this is why we see more apnea during REM sleep, because the airway muscle tone gets much lower. However, these sleep cycles, both REM and non-REM, seem to play a very important role in memory, consolidation, and in repair and recovery of body tissues. So this is just what the sleep cycle looks like during the night. The red areas are the REM periods of sleep. You can see how they start to predominate in the second half of the night. I just wanted to show you that. So it turns out that non-REM or slow wave sleep is important for encoding memory of people, places, and occurrences that went on during the day. So the things that we take on become somewhat integrated into the brain during a good quality sleep. And REM sleep seems to be more important for helping to encode memories for how to do things, what's called procedural memory, or hands-on kind of memory, riding a bike, playing the piano, manipulation, that sort of thing. And so it's rather interesting what we're starting to learn about. And, you know, the best analogy I could come up with is that it's like syncing your iPhone to your computer at night, where you plug it in and everything from the computer goes down onto your laptop or your desktop, and it gets integrated into the hard drive where it's stably stored for future reference. And so, yeah, it's kind of like that is the best analogy I could come up with. And the part of the brain that encodes a lot of learning and memory is the hippocampus. And that's the area in the green, let's see. Yeah, that's the area in the green that you can see in this slide. And it sits in the medial part of the temporal lobes. And it's a very interesting area. So not only does it help to encode visual memories and events and the people and places that we meet and greet, it also plays some role in the regulation of mood and emotion. And one of the ways the hippocampus works its magic is that there's neuron cell production is ongoing in the hippocampus. You can see at the bottom of the slide the color of the cells that goes from yellow to green to red. So that's meant to represent how new neurons integrate themselves into the hippocampal circuitry over a course of days and weeks and months. And over time, this is how new memories are laid down. And anything that disturbs this process is not good for memory. Okay, what would disturb it? Bad sleep apnea would disturb it, with low oxygenation or frequent fragmentation of sleep. High levels of stress and high levels of cortisol might disturb this process. And inflammation might disturb this process. And those are just some of the ones we know about, and there's probably others that we don't know about. But this is sort of the biological connection between sleep and memory and the hippocampus. And the other area that's important is the prefrontal cortex, the area in purple. So our most human attributes can be a result of what goes on in the prefrontal lobes. And there are connections between the hippocampus and some of these frontal areas. And the frontal areas play a role in planning, organizing, behavioral self-regulation, sophisticated social behavior that is, while it's not uniquely human, it's certainly observed to a high degree. And this is another area of the brain that's vulnerable both in untreated sleep apnea and in many of the mental illnesses and mental health disorders that we see. So there's a lot of focus and attention on these areas of the brain. Let's get more direct.
Dr. George, I think a couple of minutes.
Okay, a couple minutes? Okay, good. So I'll just show you 4 or 5 more slides. So does sleep apnea contribute to depression? Let me show you what I think is the case. As I mentioned about the hippocampus, it's not only important for memory, it's important for mood regulation. It acts as kind of a barometer, and it weighs what's going on in the environment, in the body, in terms of emotionally laden content, and helps us to make decisions based on that emotional information. And long-term changes in the hippocampus, there'll be a breakdown in that ability. So I just want to show you some individuals who came to our clinic over the last 10 years or so who were diagnosed with a depression, and they're in the column on the left, and the control subjects with Down syndrome who are in the column on the right. I want to show you this graphically because it's easier to appreciate. If you arrange their psychiatric symptoms along a radial scale, the people with depression are in blue, and you can see they take up a lot of area under the psychiatric symptom umbrella, whereas people who are controls, so to speak, with Down syndrome, without mental health problems, are in the green. And you know, when they come into your clinic, they look different and the stories are different, so it's no problem telling them apart. But when you get a sleep study on these individuals, we got sleep studies on 28, and there was significant differences in the amount of apnea or hypopnea, especially in REM sleep, and something called respiratory disturbance, which is something that's some of these things are less than an apnea or less than a hypopnea, but they contribute to sleep problems. All of this was elevated, as was a lower level of baseline oxygen. And I'll just show you this, that in people with major depression, the top row, 86% of those subjects that I just showed you, 86% had sleep apnea, and 54 had moderate to severe, 32% had mild, whereas if you look at those without a mental health condition, only 11% had moderate or severe. Most of what they had was mild or no apnea. And this occurred in people who had had their tonsils out as children. So again, it wasn't protective. I just want to say that we looked at the same phenomenon in people with anxiety and compulsive behavior who didn't necessarily have depression, but they had an exacerbation or a change in behavior. And we found about 70% had sleep apnea. So it seems to coexist with mental health issues and maybe obesity quite a lot of the time. I just will end by saying, in terms of what you do, you need to suspect sleep disorder in people who are having behavior or mental health changes, especially if it involves a decline in function and depression-like symptoms. Or if someone is not responding to the medication treatment or has a very unstable mood situation, because poor sleep can drive these things to be worse. As I said, sleep apnea may not be obvious. Previous tonsil and adenoidectomy is no guarantee, and obesity may not be present. So you have to go looking for this. And remember, this is what's at stake, right? There's sync in progress during sleep. So you don't want to just unplug your iPhone in the middle of the sync. All right? Thank you.
Thank you very much, Dr. George. And we can take a couple of questions. Yes?
Questions? Oh, okay, I'm sorry. Sure. Over here?
Can a mic be given?
That was a very beautiful and eye-opening presentation for all of us. I really wanted to know, in India, I don't know about the rest of the place, but at least where I am in Pune or in Bombay or nearby, where sleep apnea tests and sleep study tests are not there and not available. And it's not very easily available to almost all of the people. And a lot of us are concerned about this, what can be done and what should be taken care of. So in case of, in available, what methods or what things we should be doing so that even if you're not being able to get those
Right.
facilities, what we should do as a preventive thing.
So a very good and important question, and this comes up everywhere too, I don't think it's just specific to India, but what do we do when a sleep study is not easily available? Plus the fact, I'll mention, that many of our subjects, our patients, don't exactly look forward to having a sleep study and being touched and being hooked up to wires and electrodes or having to sleep in a place that's unfamiliar to them. So a couple things you can do. If you're willing to stand guard at night between 3 and 5 or 3 and 6 a.m., it would be good to video or audio record your child's sleep. And you may be able to both witness apnea and hear it on the recording. And you may be able to take that to an ear, nose, and throat doctor or another doctor who would be willing to prescribe treatment for sleep apnea based on your evidence and based on maybe looking at the airway themselves. If it's an adult who still has tonsils in place and there's clearly severe apnea, especially with these other complicating factors going on, I think you have a good argument for saying, let's get those tonsils out, let's try and lose some weight, and in the meantime, let's sleep on an inclined position to minimize symptoms. So I think those are some of the practical things you can do to literally petition the doctor about what may need to be done. Because they're certainly not going to be witnessing it unless you bring them the evidence. Yeah.
Thank you. Any more questions? Yes.
How often do you prescribe antipsychotics in obesity? Can you repeat?
No. How?
often do you prescribe antipsychotics in obesity?
In obesity.
How often do I
Prescribe.
Oh, not for obesity. Not for obesity. The connection I was drawing is that it tends to result in obesity. And so if you're treating someone with a psychotic-like condition, they may have a tendency to gain weight. Even if appetite is not visibly increased and you're controlling access to food, they may still have a tendency to gain weight. So my thought there is, how long do they need to be on this medicine? Can we withdraw it or can we switch it to something that's less offending? Yeah.
Any more questions? Yes.
Yeah.
So I'm
Just a
father
couple
of
more,
a
please.
13-year-old Down syndrome baby. My son, I'm a doctor. Once I come from the hospital, my son wants I should be with him all the time. And his behavior started changing when I have to rush for emergency call to the hospital. What he would do, he would hide my shoes, and gradually he started throwing away my shoes so that my father, once the shoes are not there, he won't go to hospital. Then he started taking the key of the car and started throwing it away. We used to keep him certain things beyond his reach. Now he has grown up. He takes a chair, he knows the place where car keys are placed, he'll throw it away so that my father doesn't go out. And gradually this behavior started turning into an aggressive behavior. And he started throwing articles of the house so that my father should be with me. And now when we used to take him to temple, he starts throwing footwear of the persons coming to the temple away. And this behavior started growing gradually more and more aggressive. After discussion with our psychiatrist at our district civil hospital, Jalandhar, we have started him on risperidone 1 milligram BD. Could you please suggest, should risperidone be tapered off, and how can we control this behavior?
Well, because of the complexity, we should talk about that individually.
Yes.
I think.
Okay.
I think it's
Yeah.
too complex to give a simple answer from the podium.
Yes.
Okay.
Okay?
Okay.
I want to just be respectful
Okay, yeah.
to the situation.
Thank you,
Right.
Dr. George, for the wonderful
Okay.
illustrious lecture. And I call upon Dr. Rekha Ramchandran to...
I have a very important
Yes.
question to ask him.
Yeah, please.
I have had the opportunity, sir. Sir, here.
Just one more
I've had
question.
the opportunity of having sleepovers with 8 years plus children with Down syndrome. So, and yesterday afternoon also I had time with the children when they slept. So I saw a 3-year-old child sleeping like a frog. And another 8-year-old girl, I don't have the video, I have recorded it, 15 minutes. She just sat and swayed and then went off to sleep this way. And when I talk to parents, they do say their children do this, but nobody is working on that at a very early stage. So I want to know, can we start sleeping on a slanting position from what early age?
So the question, as you heard, had to do with sleep position, where children will spread their hips open and sleep bent forward. And that was mentioned yesterday by a couple of the speakers about how we see not just restlessness, but we see some of these unusual positions. And in and of itself, it does not mean sleep apnea. Some children discover that as a comfort position based on their low tone, ligamentous laxity, and tendency to do what's been called do things through the midline in terms of their motor patterns. So it becomes kind of a comfort position for a lot of kids. And it's not necessarily something that you should always try and correct, although the physical therapist will tell you it's not good for hips, and it may contribute to hip subluxation if the person has dysplastic hip joint. I don't think you need to train every young child to sleep on their back. That would be a really tough struggle. You know, they do what they want to do, unless you want to Velcro them to the bed. Yeah, so I'm not sure what to say about that, except that you need to just keep an eye on this. Yeah, and we could talk more about this.
One more last small question.
Okay?
Yeah.
Yeah, Dr. Chopra,
here, sir.
there, that side.
This side.
Yes.
All Down syndrome children, they have hypotonia, and majority of them, they have the sleep apneas. So would you advise the slanting bed for all of them? That's a question. Would you advise
so
slanting
do I
bed?
recommend a slanting bed?
Yes, for
Just-
all the children with Down
Just
syndrome.
routinely.
Routinely.
Well, if your older child, maybe not your youngest child, but if your older child can adapt to sitting in a semi-reclined position, that would probably be fun.
How old is older then?
Good.
How
I don't
old
know
is
that
older?
it's going to prevent everything from occurring.
Okay. Okay, thank you.
Thank you very much. In the concern of time, may I request Dr. George to come on the stage to receive a token of appreciation from Dr. Rekha? Yeah. Please come over, sir. Dr. George. Yeah?
Come over here.
Thank you so much. Thank you very much. This is amazing.
I'm even more
Yeah.
blessed.
Yeah. Thank you. And with this, we close this session and move on to the next.
So now Dr. Rekha ma'am is going to have a session. It's going to be a discussion with the self-advocates. I would like to invite Dr. Rekha.
Hello, for all those who asked those questions about sleep apnea, we will tell you where you can seek your help, okay? Because I think on this platform it's very important, because otherwise you'll be calling every day. My child hasn't slept. Hold on, we'll tell you exactly where it's available. Dr. Suresh has people who have done just this. Oh, sorry, Dr. Priya, both of them are in the field. So we will help you. You all our doctors are in the south, okay? Sorry for you guys, but you have to move to the south. 1 second, hold on. All, come to Chennai.
These studies are available in Ramachandra Medical College. It's a university, deemed university, present in Chennai. So you can Google on the site and you'll be able to connect. The lowest age where the studies are available are not very clear, but it's definitely available for slightly older children. Thank you. Ramachandra Medical University.
It's also available in Malar hospitals, in MURF, that is ENT Research Foundation, and also in Nitra. Fortis Malar, MURF and Nitra along. Fortis Malar. Yeah, Fortis Malar. Yeah.
All you have to do is to contact us. हो गया आपका काम. I am taking leave of this the program, the Self Advocates. I am handing it over to my favorite brother. Anil Joshi will now take over from me because I have some interviews outside. Thank you. Call. Devanshi, ऊपर चलो. Palak, Pranay, and where is Sharan? Oh, Alan. Alan, where are you? Yeah. Okay. All right. Alan, come. Go up there and they'll ask you, okay? I'm sorry, I'm very busy. I have too many interviews.
I think so.
This is different. In this, the time is scheduled in the afternoon. This, the time is scheduled in the afternoon. But now, in November, we're studying something different.
Is that so? Okay. You all understand English, or if you are not comfortable in English, you can answer in Hindi as well. So while the arrangements are getting done, I think we all are comfortable standing also. Is that okay? Yes? Okay. So I will request each one of you to introduce yourself first, and then I'll ask you a couple of questions which you can answer either in Hindi or English, right? Okay, we can start from there, from Pranay. Please tell your name and where you come from and what do you do in just 2 sentences.
I am Pranay Bode. Hello, I am Pranay Bode from Mumbai. I am working in Hattedera in Mumbai in Delhi East. So,
Yes, that's okay. Yeah. देवांशी, आपका नाम बताओ, आप क्या करते हो और कहाँ से हो?
I am Devanshi Joshi from New Delhi. I am right now working as a store assistant at Gram Bharat.
बस, thank you. आपका नाम बताइए.
My name is Alan Joseph.
Alan. Okay, great. Where do you come from?
Kerala.
Kerala. Which place?
Huh?
Which place in Kerala?
Tengassery. Tengassery.
Okay. Yeah. Thank you.
Hello everyone. My name is Stein. I am very happy to see you here. I come from Ahmedabad only. And I want to thank to my president of Chennai. These are my words to say these words to ma'am. And hopeful we have a great day here. So
Yeah.
thank you.
Yeah. Thank you. Give it to Palak. Thank you.
Hello, my name is Palak Odia. You are my from Gujarat.
Which place?
Gujarat in India.
नहीं, which place? जगह का नाम, गांव का नाम बताओ.
Navsari.
नवसारी. हाँ.
Navsari, Gujarat.
Thank you, Palak. Yeah. Alan.
Abhishek Dubey. Thank you.
आपका नाम बताइए और आप कहाँ से हो?
MP. MP.
MP. हाँ. आपका नाम?
Abhishek.
अभिषेक दुबे. पूरा नाम बताओ. या करण.
Hi everyone, I'm Karan and I'm placed from Chennai, Ananagar, and I'm degree complete, Lada College.
Right. Thank you. So let's all welcome our self-advocates. Please come. Dubey, Abhishek. Abhishek, you have to be here. आप आइए इधर. हाँ. One more. Okay. हाँ. आपका नाम बताइए, आप कहाँ से आए हो?
मेरा नाम है माय असनूरदीप सिंह.
Okay.
और मैं मौज के साथ दिन में करूँगा और कभी अपना मम्मा पापा को बहुत खुश करना चाहिए.
अच्छा, ठीक है.
Thank you. And Dr. Bhavleen Kaur. She's and Nahan Medical College Hospital and मैं आपको किसी को जॉब दूंगा. बड़ी अच्छी नाम दूंगा. Thank you.
आप उधर आइए.
और कभी जिंदगी में बहुत प्यार करता हूँ दीदी से. आई लव यू दीदी.
चलो, थैंक यू बेटा. बैठो. अभिषेक, आपने यहीं बैठना. मैं आपसे कुछ सवाल पूछूंगा अभी. बस नहीं अभी. अच्छा. हाँ, आपका नाम बताइए. आप कहाँ से हो?
इंडिया मशहूर. इंडिया.
इंडिया. कौन सी जगह से आए हैं?
शुभम.
शुभम.
सर.
थैंक यू. और आप कहाँ से आए?
टोडियाट.
टोडियाड.
टोडियाट. टोडियाट.
अच्छा, ठीक है. थैंक यू.
आगे आगे दशमंदर नाम आगे साथ है. मैं आज.
Okay. But I mean, you can while I'll take care of that. आप जोर से बोलना है, please.
देखिए आज. ये मेरा.
Okay. How many?
ये मेरा.
आप सब यहाँ आ जाइए. Please.
ये मेरा साथ है. ये मेरा साथ है.
ठीक है. थैंक यू. आप यहीं बैठो, यहीं खड़े रहो. अब मुझे बताना, हम इंट्रोडक्शन कर लेते हैं. बताओ आरती.
My name is Rati, Down syndrome.
आप कहाँ से आए? Where are you from?
I'm from Chennai.
Chennai. Okay, thank you. Pass it on.
My name is Karthik, coming from Bangalore, working in Global Labs in Bangalore.
You're from Bangalore?
Yes.
Okay, let's welcome. Yeah.
And I'm working in Global Labs in a project institute.
Okay, thank you and welcome. Come in the center. Yeah.
I am Mehmet Shams. I am from Coimbatore.
Ganesh. Okay?
Yeah.
Okay, thank you. Vimal. Okay. Vimal.
Yes.
Okay, welcome Vimal.
Yeah.
You are now in Coimbatore.
Yes.
Okay, welcome to India.
Yeah.
How do you find India?
What?
You are getting friends? You are making friends here?
Yes.
Okay. Thank you.
Thank
Yeah.
you. Babu, Nai. Babu, Nai. Babu, is 17. Babu, Ami, I. Is here. Babu, Nai. Is Simon, is Simonum. Then is Simonum. Then is Simonum. Then is Simonum.
Okay, thank you. आप कर लो. आप आइए. आपका नाम बताओ.
मेघा कंदा.
मेघा कल्ला. कहाँ से हो आप?
जलंधर.
जलंधर से आए हो. चलो वेलकम. मुस्कान.
Hi, my name is Muskan. मैं जामनगर आई हूँ. जामनगर आई हूँ. मैं जाती आई हूँ गुजरात.
जामनगर गुजरात से आई है मुस्कान. ओके, थैंक यू सो मच. ओम. हाँ, एक मिनट. ओम का नाम लिया है तो ओम को बाद में आपको बुलाता हूँ.
My name is ओमलाल. मैं गुजरात से हूँ. अहमदाबाद में हूँ.
अहमदाबाद से हो. थैंक यू एंड वेलकम. क्या नाम बताओ आपका?
Ishmunter. Ishmunter.
इश्मीत.
Ishmunter.
अच्छा. और आप कहाँ से आए हो?
Kakinter.
लुधियाना.
Kakinter. Kakinter.
ठीक है, वेलकम. हाँ.
तो किसान तो कैसल और सोमिंटर पपाई.
ओके.
पपाई हारोदी मैंने हारोदी.
चलो ठीक है, थैंक यू.
अंकल जी.
या रश्मि आप इधर आ जाओ. हाँ. आपका नाम बताइए. नाम और कहाँ से आए? नेम.
My name is Karthik. Coming from Bangalore.
You are coming from Bangalore.
Yes.
Okay. And what do you do?
And learning Sanskrit.
You are learning Sanskrit. Very good.
Left. English.
Right. आपका नाम बताएं.
आलमाशन.
कहाँ से हो? आंचल.
दिल्ली.
दिल्ली से. और आप क्या करते हो? क्या करते हो? स्कूल जाते हो?
होमवर्क.
हाँ, होमवर्क करते हैं. अच्छा, चलो वेलकम. रश्मि रेखा is an accomplished dancer, right?
Okay, sir.
Okay, and she performs at the Odissi. Press of button. आप बताइए.
Okay, sir. नाम रश्मि रेखा साहू.
रश्मि रेखा साहू.
From भुवनेश्वर, उड़ीसा.
भुवनेश्वर, उड़ीसा. और आपकी हॉबीज क्या है?
बरमपुर.
अच्छा, very good.
Thank you
Welcome.
so much.
Odissi dance.
Odissi dance.
Okay, she is an accomplished dancer, right?
Okay, thank you.
And you are a national awardee also.
Okay.
Okay.
Thank you.
हाँ,
My name is Diju. I see Kerala.
കോഴിക്കോട്
You are working for someone?
Yes. Right. APJ.
अच्छा, आपको बताना है, आपका नाम बताओ।
मैं जरूर आरिफ और मैं वैजाग पैक्यम।
अच्छा, वैजाग से आए हैं। ओके, थैंक यू एंड वेलकम। अच्छा, अभी मुझे 2-3 सवाल आप लोगों से पूछने हैं। हाँ, आइए, आपका नाम बताइए। प्लीज टेल योर नेम। जोर से, थोड़ा जोर से। ओके, कहाँ से आए? ओके, वेलकम। राइट, थैंक। कम, आपका नाम बताइए। प्लीज टेल योर नेम। यू आर फ्रॉम? कोडाईकनाल। कोझिकोड। ओके।
केरला ने की उरे एमएलए
ओके, जोली
एमएलए जी मंदिर।
ओके, वेलकम। सो वी हैव no, he has introduced. No, you have introduced yourself. Okay, so yeah, आपका नाम बताएं। हाँ, नाम बताओ।
हमारा नाम
ओके, या अभी हम एक काम करेंगे, सब लोग सामने आ जाएंगे। हाँ, या जिन्होंने नाम नहीं बताया, दे शुड कम दिस साइड सो दैट दे कैन इंट्रोड्यूस देमसेल्व्स। आपका नाम बताइए। वेलकम, बताइए आपका नाम। वेयर आर यू फ्रॉम? कोझिकोड। आपका नाम बताइए। प्लीज टेल योर नेम।
केरला।
केरला। नेम?
Gibinjabi.
Okay, yeah, thank you and welcome. Please come in the front. सब लोग आप सामने आ जाइए. We'll have a group photograph and see, we have such a diverse group coming from across the country. They have their abilities and पीछे रखें. अच्छा, no, please stand here. हाँ, हाँ, ठीक है. ये पीछे रख देंगे. हाँ. पलकच्या बाजूला. रश्मी रेखा पलकच्या बाजूला. छोटे आप सामने आइए. आप सामने थोड़ा आप इधर. रश्मि इधर आ जाओ. आप यहाँ आ जाओ. थोड़ा इधर आ जाओ. बेटा आप इधर. Okay. Please tell your name.
Hello, Rick. Yes, Ivan Sangar. Hamanadu, India. Thank you.
See, our children have so many commonalities that, it cuts across all the barriers as who is my child, who is coming from Kerala, who is coming from Tamil Nadu. So let's all appreciate the uniformity of feelings which comes to all of us as parents because of thanks to our children. There are differences in height, there are differences in language and the speech they have, but yet there are so many similarities which makes us all a great extended family. If we may not remember each one's name, like if you ask me each child's name, it will be beyond my human capacity. But yet, all are our children, and let's extend our wholehearted love and affection to all the children who are not here, who may not be known, may not be seen, but they are very much there in the society, and that is the spirit which Rekha Ma has inculcated in each one of us. So we have been touched upon by this blessing, which is really so unique, and it makes us emerge as better human beings. You'll all agree with me. Thank you so much. If the photographs are done, I will. हाँ, अभी गाना बोलेंगे. So Rashmi Rekha Sahu will sing a song. Parents, I'll please request you all to occupy your seats. I'll also come down. सब छोटा बच्चा, please come. आप यहाँ सब छोटा बच्चे यहाँ. I'll request all the parents to occupy their own seats, and as we arrange the children. हाँ बेटा, हाँ बेटा, फोटो ले रहे हैं तो प्लीज कम. So I'll request this house to resolve that each one of us is going to make an effort in a sustained way every time the opportunity presents itself to reach out to the new parents, new families, and handle with them to bring all our children to the levels we have done to our own children. With that, I think the session should be handed over to the photographers, and once they are done, I'll have done my job. Thank you so much.